Dear colleagues, let me introduce you to my presentation for Best Research Award at International Conference on Psychiatry and Mental Health, titled Retrospective Analysis of Sleep Patterns in Patients with Chronic Disorders of Consciousness. My name is Julia Nekrasova, and I'm a researcher in Federal Research and Clinical Center of Intensive Care Medicine and Rehabilitology, Moscow, Russia. As an epigraph to my work, I choose a quote from Carl Jung. In all chaos, there is a cosmos. In all disorder, a secret order. It is very suitable for what we do working with patients with impaired consciousness. We look for the cosmos in the chaos, for some order. In total disorder, we try to communicate with silence. And this is the mission of our center. Detection of minimal signs of consciousness has great clinical importance. It changes the vector from palliative care to rehabilitation. It makes it possible to give relatives hope for a better outcome for their loved ones. And here, analysis of sleep can help us because sleep is considered a key to consciousness. If one understands sleep, it becomes possible to peer into the inside of the brain. But if the brain is injured, the sleep is also disrupted and distorted, and the very existence of normal sleep in patients in a vegetative or minimally conscious state is still a matter of debate. However, the neurophysiology of sleep, which has been thoroughly studied in healthy people, suggests that the presence of sleep correlates with normal cognitive and emotional processes in wakefulness, with memory consolidation, hormonal regulation, functioning of the immune system. Thus, it can be stated that restoring and maintaining circadian rhythms can help regain consciousness and improve the overall somatic condition of patients. So, what do we know about sleep in DOC patients? The information on this topic is largely contradictory. For example, Landsness denies having any sleep patterns in all his patients. However, Bedini finds normal sleep patterns in all participants. The characteristic graphical elements of sleep, such as sleep spindles and K-complexes, are periodically found in greater or lesser amount. The aim of our study was to analyze sleep patterns by polysomnography and to develop specific criteria for analyzing sleep in patients with DOC. 40 adult patients participated in the study. Inclusion criteria involved persistent vegetative or minimally conscious state due to severe acquired brain damage of different etiology, such as traumatic brain injury, anoxic brain injury, vascular lesions, inflammatory diseases. Time since injury substituted less than a year, but not less than 1 month at the study enrollment. Exclusion criteria comprised age over 70 years old, disability associated with the central nervous system that preceded the insult, epilepsy, myoclonus, hemodynamic instability, the need for mechanical ventilation, which can interfere with sleep. No more than 2 days before the enrollment in the study, 2 trained and certified neurologists evaluated all patients and determined the level of consciousness according to the CRSR scale. Given the fluctuations of the clinical responses in DOC patients, a reassessment was carried out 1 week after the beginning of the study. No less than 3 months after the discharge, catamnestic data were acquired for each patient to assess the outcome of the disease and evaluate prognostic significance of sleep patterns. Polysomnographic recording of all patients were obtained overnight from the afternoon or evening of the previous day to the morning of the following day with SomnoScreen Plus PSG system. We developed a specialized software in Python programming language with the use of open source libraries, which provides bandpass filtering, artifact removal, detection of characteristic graphical elements such as sleep spindles, slow waves, etc. Each epoch is automatically scored in compliance with Rechtschaffen and Kale's criteria, which are represented as the body of knowledge, if they are rules, of the expert system, or logical artificial intelligence. According to the results of AI scoring, it's possible to automatically construct a hypnogram for each patient. According to the results of the analysis, the nature of the change in sleep patterns in patients with DOC can be divided into 3 groups. First, no change in sleep stages. Typically, the EEG of these patients is characterized by a dominant diffused delta or theta activity, sometimes in conjunction with activity in the beta range due to muscle tension. Second, a disorganized change in sleep stages that does not correspond to the normal sleep cycle of a healthy person and is a chaotic change in activity on a hypnogram. And third, rhythmic change in sleep patterns. In this case, there is a cyclic change in brain activity. We consider this variant as an evidence of the presence of a sleep-wake cycle, albeit distorted and disrupted. It can be seen from the pie chart that the rhythmic change in sleep patterns is observed only in 12.5% of the participants. It has only in 5 patients out of 40. They had close to normal sleep-wake cycle. All of them were in minimally conscious state plus and had the highest scores on the CRSR scale from 14 to 17. Statistical analysis revealed thus a direct, moderate correlation between the nature of the stage change and the CRSR scores. It should also be noted that all patients with a rhythmic sleep pattern had traumatic brain injury. Moreover, there is a direct, moderate correlation between the presence of sleep and the outcome of the disease. So patients with rhythmic change of sleep patterns had better outcome. However, a number of serious restrictions of the polysomnographic methods and also limitations of the study must be taken into account. First, polysomnographic method is not adequately informative in cases of significant damage to the cerebral cortex, like a loss of most of the cortical neurons, a drastic decrease in the number of interneuron connections in the cerebral cortex, diffuse axonal damage with subsequent degeneration of cortical neurons, reduction in the activity of the caudal group of nuclei of the basal forebrain. Diffuse lesions to the cerebral cortex lead to quantitative decrease in the main functional units of the nervous system and their connections, which is electrophysiologically converted into a slowdown in cortical rhythm, and their inability to translate high-frequency activity of subcortical structures. In our study of difficult patients with serious lesions to cerebral cortex, the aforementioned considerations resulted in complete absence of sleep spindles visible on the EEG. Thus, the methods for analysis of sleep in DOC patients would most likely require serious improvement and reconsideration. Another problem arises when recording PSG in intensive care units. Receiving signals which are of acceptable quality in ICUs is a notably demanding task because common artifacts caused by perspiration, skull and skin deformities, thermal dysregulation, physiological processes of breathing, eye movements, as well as additional artifacts from technical devices that can be caused by resuscitation equipment, medical manipulations, etc. All this can entail completely unpredictable results of the study. And I will add that a remarkably low percentage of patients with a rhythmic change of sleep patterns, this 12.5%, can indicate not only the bad prognosis and low level of consciousness, but also the prevalence of violations of sleep-wake cycle, which is typical in patients in vegetative and minimally conscious state. External factors, such as the lack of sunlight, artificial lighting, noise stimulus, and so on, can cause these disorders. Authors believe that restoring and maintaining circadian rhythms can not only help patients regain consciousness and improve the overall somatic condition, but also to improve the accuracy of the PSG method of sleep study. In accordance with previous works, current study confirms the clinical validity of the presence of sleep patterns for diagnosis and prognosis of the chronic DOC. The differential diagnosis between persistent vegetative state and minimally conscious state is confirmed to be possible via PSG sleep analysis. We state that rhythmic change in sleep stages can be considered as a marker of high level of consciousness and a predictor of better outcome. However, our study raises an issue of incomplete informability of PSG method and brings up the question of finding new ways to analyze sleep patterns in chronic DOC patients, either as standalone methods or in combination with PSG. These methods can include actigraphy or any kind of muscle activity monitoring, video monitoring for a facial zone to detect eye blinks, and so on. We consider this our further task. Thank you very much for your attention. This presentation has been made in memoriam of a good doctor, Professor Igor Pryanikov. Thank you.